Hello to everybody. My name is Andrea Truini. I work in Rome at Sapienza University. I'm a neurologist and I'm going to show you in my pre-recorded presentation the different options for treating patients with trigeminal neuralgia. I do hope that you will enjoy my presentation. As you know, trigeminal neuralgia is a special neuropathic pain condition for many reasons, including, as we will see, the pharmacological treatment. Differently from all the other neuropathic pain conditions, trigeminal neuralgia has an excellent response to specific pharmacological treatments. This excellent response to specific drugs derives from the very peculiar pathophysiological mechanism underlying the classical paroxysmal pain patients with trigeminal neuralgia suffer from. You know that classical trigeminal neuralgia is due to a neurovascular compression. Usually the superior cerebellar artery compresses the trigeminal nerve root. Conversely, secondary trigeminal neuralgia is due to posterior fossa tumor compressing the trigeminal nerve root or demyelinating plaque at the trigeminal root entry zone. It follows that in both types of trigeminal neuralgia, a short tract of the primary afferent lose their myelin sheath, as confirmed by neurophysiological, neuroimaging, or histological evidence. In particular, this slide shows a comparison between a normal trigeminal nerve root in an animal and a trigeminal nerve root in a patient with trigeminal neuralgia. The main abnormality consists of a damage to the myelin sheath, mainly affecting the large myelinating nerve fibers. Many animal studies demonstrated that the focal demyelination triggers high-frequency discharges from large myelinating fibers. In particular, these figures show experimentally induced demyelination of the dorsal columns of animals. The recording shows spontaneous high-frequency discharges and an abnormal sensitivity to mechanical stimulation of the dorsal columns. So, paroxysmal pain in patients with trigeminal neuralgia is due to the focal demyelination of the trigeminal nerve root, provoking ectopic generation of impulses with high-frequency after discharges and haptic transmission. We have many drugs with the potential of treating effectively pain in patients with trigeminal neuralgia. However, only carbamazepine and oxcarbazepine received a strong recommendation for use in recent guidelines for the management of trigeminal neuralgia issued by the European Academy of Neurology. The quality of the evidence supporting their efficacy is quite low, but the effect size and the widely established clinical use make these drugs first-line drugs for patients with trigeminal neuralgia. The number needed to treat of carbamazepine in patients with trigeminal neuralgia is 1.7. The same for oxcarbazepine. You may consider that the number needed to treat of pregabalin in painful neuropathy is about 6. This gives you an idea on how carbamazepine and oxcarbazepine are effective. This excellent response to carbamazepine and oxcarbazepine directly reflects the mechanism underlying paroxysmal pain. These two drugs are voltage-gated sodium channel blockers, and thus they reduces the abnormal high-frequency discharges provoking pain. Second-line drugs include lamotrigine and gabapentinoids. Lamotrigine is supported by several evidence if used as an add-on therapy. Unfortunately, the comparatively high risk of dermatitis imposes a very slow titration. Gabapentinoids are often used as an add-on to oxcarbazepine or carbamazepine in patients with trigeminal neuralgia with concomitant continuous pain. However, a dedicated clinical trial has never been reported in trigeminal neuralgia with concomitant continuous pain. While it is reasonably expected that carbamazepine and oxcarbazepine have a similar effectiveness, clinical experience and open studies suggest that oxcarbazepine has a more favorable safety profile. This study includes 200 patients treated with carbamazepine and oxcarbazepine. The initial number of responders with both drugs approached to 100%. However, about 30% of patients treated with carbamazepine incurred in adverse events that directly caused interruption of treatment by the physician or a dosage reduction to a level that was insufficient to control pain. Conversely, physician or patient-decided discontinuations occurred in 18% of patients initially responders to oxcarbazepine. Except aponatremia, all the other side effects were more frequent with carbamazepine than oxcarbazepine. Among patients who had a good initial response, only 3 patients with carbamazepine and 2 with oxcarbazepine developed later resistance, therefore indicating that, unlike common notion, in our large patient sample, the worsening of pain with time and the development of late resistance occurred in a very small minority of patients. For those patients with contraindication for carbamazepine or oxcarbazepine, alternative drugs like lamotrigine or gabapentinoids can be tried as monotherapy or add-on therapy. Often, these patients is eventually referred for surgery. Botulinum toxin injections of the trigger areas might be tried as a potential alternative to surgery. Concerning the surgical approach, an important and difficult question is we should offer early surgery. For instance, one study in patients who received surgery for trigeminal neuralgia found that many patients, after experiencing the long-lasting benefit of the surgery, would have opted for surgery from the very beginning. My personal view is that the first treatment for classical trigeminal neuralgia should be oxcarbazepine or carbamazepine, and surgery should be proposed only if the standard dosages are not sufficient or the side effects are too severe. The first group of surgical interventions involved peripheral lesions of the trigeminal terminal nerves at their emergence from the facial bones. Surgical methods include neurectomy, alcohol injections, radiofrequency lesioning, or cryolesioning. However, this group of extremely peripheral surgical intervention has never been supported by adequate trials and has often been the source of anesthesia dolorosa. The main groups of surgical interventions include percutaneous trigeminal ganglion lesions, gamma knife procedures, and microvascular decompression. Percutaneous trigeminal ganglion lesions include 3 main surgical methods: radiofrequency thermocoagulation, mechanical lesions by injection of high concentration glycerol, and mechanical compression by balloon inflation. Accepting some variability in the follow-up duration, about more than 50% of patients obtain pain relief with these procedures. Multiple procedures are allowed potentially, but the risk of anesthesia dolorosa must be considered, because the risk of anesthesia dolorosa increases with the number of procedures. Gamma knife is the most recent surgical procedure, and it is strongly supported by increasing evidence. Unlike other procedures, however, the pain-relieving effect requires 6-8 weeks to develop. According to the latest guidelines, about 50% of patients has pain relief with this procedure. Microvascular decompression is the only causal treatment. During this procedure, the neurosurgeon inserts a small sponge to keep the pulsating artery separated from the trigeminal root. Meta-analysis of the largest studies have demonstrated that microvascular decompression is the most effective surgical intervention for classical trigeminal neuralgia. At 1-2 years after the procedure, about 70% of patients still have pain relief. So, thank you for watching this pre-recorded presentation. I do hope that this presentation will be useful for your everyday clinical practice.